So, okay, so can you give me the DDs? First is pulmonary tuberculosis. Yes, some more DDs for this case, or what you think this could be? Co-workers pneumonitis. Okay. 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 So first there is shortness of breath and chest tightness. There is chronic cough with expectoration of jet black sputum. Radiological examination of chest X-ray shows nodularities in the upper lobe of the lungs. So, what are the investigations that you? So for DDs, you have given pneumonia, TB, and pneumoconiosis, co-workers pneumoconiosis. So, what are the investigations that you will carry out along with the history, and what will be the relevant history that you will ask, and possible diagnosis? You've already told me about those. So, can you tell me about the investigations that you will carry out? History diagnosis. Yes. First, you can do sputum examination, chest X-ray. Some more. Yes, occupation history is very important. Okay, so you will, yes, history of smoking. So you will also do lung function test, okay? So yes, investigation that we do will be chest X-rays. We will do CT scan and lung function test, okay, by spirometry. So on chest X-rays, what we saw was nodularity in the upper zones, okay? So, and for histories, for history, you will have to ask about the occupational history. And if there is any history of exposure, then you have to ask the duration of exposure to dust, like minerals and all that. And also you have to ask the duration of disease, and you have to ask for history of smoking, and also history of tuberculosis. So first we will discuss differential diagnosis one by one, okay? So first coming to TB. So we said that TB could be the TB can be one of the differential. So how will you differentiate from the other diseases? So for TB, you can do. Can you tell me what are the tests you can do? Screening test as well as gold standard test for TB. So yes. So for we can do Mentos test, okay, where you inject purified protein derivative. You can do Mentos test for screening, and you can also test for sputum. You can do ZN stain, or gold standard is culture, that is Lowenstein Jensen stain culture, which is the gold standard. Okay, so first, these are the examinations that you can do. First, you can do Mento test, and sputum you can test for AFP stain, and you can also do culture. And for history, what are the history that a patient of tuberculosis will give? So on history, he will also give history of contact or previous history of past history of tuberculosis. Okay, and on clinical symptoms, in case of TB, patient can present with fever, malaise, night sweats, weight loss, and there will also be cough with expectorations, and sometimes there can be hemoptysis. And on that examination can show lymphocytosis. So these are the features in tuberculosis. Okay. So other one is miliary tuberculosis. This will also show nodularity on X-ray, and but it can also affect other sites such as, can you name other sites where it will like disseminate tuberculosis? So it can also go to spleen, liver, bones, lymph node. Yes. So first we discussed about TB and miliary TB, and other differential will be silicosis. Okay, for silicosis too, you will take history, occupational history, and you will ask about clinical features. And in case of silicosis, there might also be pleural thickening. And on X-ray, even this shows nodularity in the upper zones of the lung, but these are much more well defined as compared to co-workers pneumoconiosis. And there you can also see eggshell calcification of the lymph nodes in case of silicosis, but this is not pathognomic of silicosis. Okay, so we discussed from the differentials, we have discussed TB, miliary tuberculosis, pulmonary TB, miliary tuberculosis, silicosis, and the other one is lung cancer. So for lung cancer, patient can present with cough, and also can give history of weight loss, dyspnea, and also give history of hemoptysis. And there might be additional history with with which the patient can present, such as like hoarseness of voice, if laryngeal nerve is involved, dysphagia, and also there can be metastasis in case of cancer. So it can affect. It can also give other symptoms, like if it affects bone, and if there is mets to bone, it can present with body ache, headache, seizures. So it depends on where it metastasizes. So that is for lung cancer. And it also can cause some paraneoplastic syndromes, such as hyponatremia due to ADH, and Cushing syndrome due to adenocorticotropic hormone, or hypocalcemia, and so on. So in lung cancers, they will also show many other features that shows that there is malignancy going on. And also you can do bronchoalveolar lavage to check for the atypical cells. So that was that TB and lung cancer. And other one is idiopathic pulmonary fibrosis. Other differential is idiopathic pulmonary fibrosis, and even here they have similar clinical presentation, where the patient is old and also presents with cough and dyspnea. Usually the cough in this case is dry cough, and it is also a type of restrictive pulmonary disease. The patient can present with cyanosis, clubbing, and what happens in co-workers is usually the upper lobes are affected, but in this case, in idiopathic pulmonary fibrosis, bilateral lower lobes, that is basilar uh, consolidations can be seen. There can also be history of cigarette smoking and gastroesophageal reflux. So to differentiate it from co-workers pneumoconiosis, we will have to ask about proper history and rule out particle exposure. Okay. And even in this case, in idiopathic pulmonary fibrosis, you can also see honeycomb change or bronchiectasis sign. So these were the differential. So final diagnosis. So final diagnosis was coworkers pneumoconiosis. Alright. So can you tell me spectrum of coworkers pneumoconiosis? So can you tell me a spectrum of coworkers pneumoconiosis? So clinical features in case of coworkers pneumoconiosis, as it was already told in the history, there will be cough, shortness of breath, chest tightness, and okay, there you can also get black expectoration. So this is the first finding. This is the case of simple coworkers pneumoconiosis, and this is where simple coworkers pneumoconiosis showing uh, black deposition, and when they coalesce together or progresses, it forms larger deposition, and then there can also be cavitation due to ischemic necrosis. So spectrum included Androphosis. This is benign and common and asymptomatic accumulation of carbon dust in the lungs. And it can also be due to smoking or just pollution, air pollution. And it is asymptomatic. In case of simple co-workers pneumoconiosis, you can either see macules and nodules. So these are mostly seen in the upper lobes or lobes of the upper zone of the lower lobes, and there can be dilatation of the alveoli adjacent to the respiratory bronchial that it affects. What are and these macules that were present that is formed due to the aggregates of macrophages that are carbon laden macrophages, and this coal nodule, they are larger and also contain delicate network of collagen fibers. So this other one is complicated coworkers pneumoconiosis, or also known as progressive massive fibrosis. It takes many years to develop, and the grossly it shows blackened scars that are usually 1 centimeter or larger. They are bilateral and present in the upper part, and also it can form cavities due to ischemic necrosis. And sometimes, if it progresses, it can also affect the lymph node and pleura. So on microscopic examination, it shows lesion shows dense collagen and pigment, and center of lesion can show necrosis. and the alveoli surrounding it are markedly dilated. So, we'll just briefly classify different type of pneumoconiosis. So, as already discussed, it is just non-neoplastic lung reaction to inhalation of inorganic and organic particles and chemical fumes and vapors. So, depending classification based on the biologic agent. So, it can be due to mineral dust or organic dust. Organic dust can cause hypersensitivity pneumonitis, or organic dust that can induce asthma, and chemical fumes and vapors. So, for each of the diseases, occupational history is very important so that you know the exposure of what kind of particles has taken place. So these are all in the factors that affect the extent of damage, the shape of the particles, solubility and physiochemical composition, duration, and additional effect of irritants such as tobacco and smoke, host factors such as efficacy of clearance mechanism and immune status of the host. So as told earlier, particles of size 5 micrometer, they reach the terminal bronchioles and are expectorated, where early and particles of size less than 5 micrometer, they reach the terminal airways and settle down on the alveolar sac lining. This is just briefly pathogenesis. And complications of cold walkers pneumoconiosis, it can lead to emphysema, chronic bronchitis, pulmonary dysfunction, hypertension, and cor pulmonale. So that was case of pneumoconiosis. We'll just summarize. So clinical features: cough, shortness of breath, chest tightness, black sputum, and these are the DDs: cold walkers pneumoconiosis, TB, miliary tuberculosis, silicosis, lung cancer, metastatic disease, and idiopathic pulmonary fibrosis. And chest X-ray, what it shows is diffuse small rounded opacities or nodules. And if calcification is present, it is present as a central dot in the nodule. Whereas in silicosis, it can also be present as an eggshell appearance. And it is more predominant in the upper lobes. And CT is more specific and sensitive as compared to chest X-ray. Yeah. And this is normal lung. And this is case of simple cold walkers pneumoconiosis with deposition. And this is progressive massive fibrosis in which there are scars formed, blackened scars are formed, and there can also be ischemic necrosis leading to cavitation. Microscopic finding. In this, the alveoli are dilated, there can be destruction, and there is accumulation of this carbon pigments. So from mineral dust, we already discussed coal dust. Now coming to second case, patient, a 50-year-old male, present with dyspnea, persistent cough, also complains of fatigue, chest pain. He gives history of working in repair and demolitions of buildings and road, and chest X-ray shows fine well-defined nodularity in upper zones of the lung. So, can you give me can you give me DDs for this? Okay, why did you tell silicosis? Can you give me some more DDs for this case? Okay. What about occupational history? That is important too, yes? Okay. So first is you give one is silicosis. Can you give me some more DDs for it other than silicosis? TB, okay. And the same thing you can do chest X-ray, chest CT, AFB stain, sputum culture, pulmonary function test, and in some cases, like sometimes tissue biopsy for confirmation, and you can also check under polarizing microscope. But like this is not in all cases. Only chest X-ray, chest CT, AFB sputum culture, pulmonary function test you can do. So silicosis, TB, chronic hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, sarcoidosis. So for TB, we already told how we can confirm if it is a case of TB. Okay. And now coming to chronic hypersensitivity pneumonitis. So what are the history? What other history will you ask in case of chronic hypersensitivity pneumonitis? So in the table that we had already discussed, some of the occupation also led to hypersensitivity, hypersensitive pneumonitis. So if you can remember. So in this case, you will also ask for history. In occupational history, you will ask if he's like farming or if it's handling of birds and so on. It is usually immunologically mediated and usually due to inhalation of organic antigens. And so in history, you will ask if he has a history of acute attack on inhalation of particular antigens, dust. And also in this case, they have similar feature of dyspnea, cough, and in blood finding, there can also be leukocytosis. And he can have a recurrent history of recurrent history of attacks, like acute attacks on inhalation of certain antigens. And on the X-rays, you will see a micronodular infiltrate in the lung parenchyma. So that was for chronic hypersensitive pneumonitis. And as discussed earlier, the other DT can be idiopathic pulmonary fibrosis. And other one is sarcoidosis. So how do you know this is not a case of, how do you rule out sarcoidosis in this case? Okay. What kind of granuloma? Okay, but that is on microscopy finding. Yes. Like, can you give like some more like clinical features or something else that you by which you can rule out that it is not sarcoidosis? So sarcoidosis, it can occur at any age, but usually like below 40, and usually female have preponderance. Okay. And it can also involve other organs, like the patient may have cutaneous lesion in form of subcutaneous nodule, or it also affect eye. There is also eye involvement, so a patient can have iriditis or glaucoma and so on, and can also affect liver or spleen. And symptoms he can present with same thing: fever, weight loss, night sweat, hemoptysis. Okay, and in X-ray finding, and there is lymph nodes are involved, and on bronchoscopic biopsy, yes, bronchoscopic biopsy of bronchial submucosa, it can show non-caseating granulomas in case of sarcoidosis. So differential was silicosis, TB, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, and sarcoidosis. So for history, we will ask about occupational history and duration of exposure, history of dyspnea, weakness, weight loss, and chest pain. So on investigation, X-ray shows fine multiple nodularity that is well defined and uniform in shape. In the upper zone, XL calcification of the lymph node will also be seen. And chest CT also shows numerous bilateral serous opacities. It is well defined compared to cold-workers pneumonitis. And subpleural nodules can also be seen. And polarizing microscopy, it shows birefringent silica particles. So silicosis, brief discussion on silicosis. It is common lung disease caused by inhalation of pro-inflammatory crystalline silicon dioxide. In gross, you can see that there is a mass that is present here in the upper lobe. And on microscope. So this is a nodule where you can see collagenous deposition, and at the periphery there is a pigment deposition. We will come to it later on. So it can occur in crystalline or amorphous form. So crystalline forms are mostly responsible for it. And this is all just pathogenesis. So onset, it can be either slow and insidious, common 10 to 30 years, accelerated within 10 years, or rapid, weeks to month. And also, people with silicosis are susceptible to tuberculosis because it inhibits the activity of macrophages to kill the ingested mycobacterium. And gross, as shown earlier, it was a well circumscribed fibrotic nodule in the upper zone. It can also have coal dust or calcification. Pleura is thickened, and nodules can also be present on the pleura and lymph node. And sometimes, if there is also tuberculosis, cavitation can be seen. Lesion is composed of collagen and peripheral zone of dust-laden macrophages. Calcium deposit may also be present. Collagen. So the third case is a 55-year-old male present with dyspnea, cough with expectoration, history of working in mines. Chest radiograph shows large pleural plaques. Lung shows bilateral irregular linear densities in the lower lobe. Can you give DD for this case? Same thing. For investigation, you will do chest X-ray, chest CT, pulmonary function test, bronchoscopy, spirometry. So differentials for that is idiopathic pulmonary fibrosis, rheumatoid arthritis, hypersensitivity pneumonitis, and emphysema. So on grossly, their plaques can be seen on the pleural surface of the diaphragm. There is pleural thickening. There is also deposition of carbon particles. And on microscopic examination, some fusiform, golden brown fusiform or beaded structures can be recognized. So what will be a diagnosis for this? Golden brown beaded structure that is translucent, and the outer side is brownish. So it is a case of asbestosis. In case of asbestosis, pleural plaques can be seen. It especially occurs on the diaphragmatic surface or anterior or lateral surface. And on microscopy, you will see these asbestos bodies. These are the asbestos bodies. So these are pro-inflammatory crystalline hydrate and asbestos erythrocytes include localized fibrous plaque, pleural effusion, asbestosis, lung carcinoma, mesothelioma. So it occurs in two forms, serpentine and amphibole. Serpentine, they can be easily removed. They're curled and flexible and are removed by mucociliary actions, but amphibole, they are straight and stiff, aligned to the atrium and get delivered to deeper to the lung. And oncogenicity is due to the free radicals that are generated by this asbestos fibers, and also due to the chemicals that are adsorbed on the surface of this. So Asbestos exposure alone can cause 5-fold increase in development of lung cancer, whereas asbestos exposure along with smoking, there is 55-fold increase in lung cancer. So morphology. There is pulmonary interstitial fibrosis with asbestos bodies. It is difficult to differentiate just on microscopy. Asbestos body will help you differentiate it from other pulmonary interstitial fibrosis. And this asbestos body are golden brown, fusiform or beaded with translucent center that is composed of asbestos fibers and is coated with iron containing proteinaceous material. And they start at the respiratory bronchiole and lower lobes and subpleurally. So these pleural plaques, they are mostly at the anterior and posterolateral aspect of the parietal pleura. They are well circumscribed plaques of collagen and can be calcified. Sometimes pleural effusion can also occur. So do you want me to summarize it again? Or do you have any questions? Do you have any questions? Okay. So I will summarize it one more time and then I will end it, okay? So this was for expectoration of jet black sputum and X-ray nodularity in upper lobe. And so differentials were this for co-workers pneumoconiosis, TB, silicosis, lung cancer, metastatic disease, idiopathic pulmonary fibrosis. And this was simple co-workers pneumoconiosis. The other one was progressive massive fibrosis. Androphosis. And there is dilatation of the alveolar sac and cold macules, which is composed of macrophages containing the carbon pigment. So, and pneumoconiosis, depending on the etiologic agent. For mineral dust, it can be due to coal dust, silica, asbestos, beryllium, iron oxide, also occupational history. And for organic dust, it can be due to moldy hay, bagasse, bird dropping, and organic dust that induces asthma. And then cotton, flax, hemp, red cedar dust, and chemical fumes and vapors. So for this case, with dyspnea cough, history of working in repair and demolition of building and road, chest X-ray shows fine, well-defined nodularity in upper genital. So differential will be silicosis, TB, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, and sarcoidosis. So for sarcoidosis, you can ask about any other manifestation in any other organs, and also about age. And for chronic hypersensitivity pneumonitis, you can ask about history of allergies or any occupational history of farming or so on. So this is the nodularity in case of silicosis. A nodule composing of collagen with macrophage-laden pigment. And on polarizing microscopy is birefringent. In dyspnea, expectoration, and radiographs show pleuroplex and lung show irregular linear densities in the lower lung. And sometimes when it progresses, it can also give honeycomb appearance. So DD is IPF, rheumatoid arthritis, hypersensitivity pneumonitis, and emphysema. So in emphysema, you can also ask about on X-rays. There is overinflation. There is overinflation with flattening of diaphragm. There is widening of the air space between the ribs, and also increase in retrosternal space. And for rheumatoid arthritis, you can also ask for if the joints are affected, and also level of rheumatoid factor. Which will be more than 14 international unit per ml. And idiopathic and hypersensitivity we already discussed with the other case. So on gross in asbestos, pleura is affected. This is on the pleural surface of the diaphragm. Fibrocollagen large, and fibrocollagenous legs, which can also be calcified. And pleural thickening can be seen. Also, there is deposition of carbon particles. And on microscopy, asbestos bodies are seen. This is So the class. Okay. Thank you.